Hi everyone, I'm Nashwa Abdulsalam. This is Heart Rhythm TV and I'm joined by Dr. Cha and Dr. Bhakta. Welcome. We're going to be talking today about global AFib management insights from recent guidelines. And my first question is, what are the pivotal changes that have been introduced to AFib management through the recent 2023 ACC, AHA, ACC, FHRS and 2024 ESC AFib guidelines?
Well, thank you. So I think the new guideline from ACC compared to the previous guideline, I think there's quite a few new pivotal changes. One of them, I feel, is the AF ablation is some patients already promoted to the first-line therapy. So especially in the patient with the paroxysmal atrial fibrillation, and the patient is highly symptomatic, but selected, the patient has less comorbidities. So those patients, is considered as a first-line therapy, equal like before recommended as a first-line therapy in antiarrhythmic drug. And also emphasize the patient with atrial fibrillation and heart failure. I think based on the multiple clinical trials, especially the two CASTLE trials, so the evidence has been supporting the patient who received the catheter ablation compared to the antiarrhythmic drug, they do better in the overall outcomes. Yeah, so that's a significant change.
Yeah, I would corroborate Dr. Cha's comments in that we've all seen the shortcomings of drug therapy and very few new therapeutic options. And the earlier approaches using catheter ablation and other such approaches in sort of high-yield populations, those with paroxysmal atrial fibrillation, heart failure patients, I think where we have known benefits, I think are emphasized in both documents. Both documents also are quite comprehensive in highlighting the inputs and comorbidities that drive atrial fibrillation and taking into account risk factors that may need to be addressed to maximize success of interventions such as catheter ablation as well.
My second question is, where do you see global alignment between these guidelines and where do they divert or differ when it comes to, the philosophy of AFib care and implementation?
I see the two documents very comprehensive and then very in detail and address the key management and in the current state. So Deepak just mentioned about that. I think the big alignment in my view is the look at the atrial fibrillation as a disease process. I think in the ACC guideline and we look at the atrial fibrillation divided into 2 or 4 stages, right? From the beginning risk factors, then to the pre-AF stage, like the PAC's atrial tachycardia, then go to the stage of atrial fibrillation and advanced stage. So I think the key to staging the atrial fibrillation is we need to take care of these patients from the very beginning. We emphasize the prevention and then manage the patient with symptoms and then prevent the atrial fibrillation progression. And so is the ESC guideline. So they emphasize the AF care pathway. So basically very similarly, so they talk about the comorbidities, the risk factors, that's prevention. Then they talk about the stroke prevention. Then talk about how to reduce the symptoms of atrial fibrillation directly to the patient with AF management. And then lastly is the evaluation and reassessment, the continuity for continued care of this patient population.
Yeah, I agree. I thought the documents were remarkably aligned despite coming from 2 different writing groups. While both advocate, for example, for earlier ablation or first-line ablation in some patients, I thought the ACC-AHA document was a little bit more specific in that younger patients with fewer comorbidities, but coming back to those risk factors, may benefit more. Interestingly, our European counterparts actually had a thoughtful section on screening for atrial fibrillation, so even preventing the onset of atrial fibrillation before more aggressive steps might be needed. But on the whole, I thought they both had some very common conclusions and complemented one another.
And shifting gears a little bit, what are the key highlights of the 2024 ERA HRS, Asia Pacific, Latin America HRS joint consensus statement? What are the key highlights that, let's start?
Yeah, I thought this was a tour de force document. I think being in an EP community at a meeting where electrophysiologists are most prominent, I thought it was very thoughtful, the approach they used in terms of talking about mechanisms of atrial fibrillation, and that even led to some discussions regarding novel targets, for example, the ligament of Marshall and so forth, other areas that are maybe not as commonly targeted or deployed. It even discusses surgical approaches to atrial fibrillation management in some patients who are either going concomitant atrial fibrillation surgery, or concomitant cardiac surgery, or perhaps have had failed ablations or unsuccessful ablations and so forth. So I thought it was very detailed and very comprehensive, talking from the beginning steps, the mechanisms, targeted interventions, and even talking about stroke reduction, surgical and catheter-based approaches to that as well, complications that can result in strategies to limit complications from procedural therapies, and follow-up steps as well, both from a training standpoint for the operators as well as care units, for example. Highlights some areas where we can maybe use best practices to limit complications and enhance outcomes and benefits for our patients.
I totally agree. I think they also emphasize the modern mapping system. That's something new because currently we have a lot of advanced 3D mapping system even for the images. And also they really aligned very well with the current ablation technologies. And then so especially like we're currently doing the PFA ablation. So I think they really provide a strong evidence to support how evolving these technologies, how do they serve, in these clinical patients who undergo the catheter ablation. So I think the overall, I think they introduced this detailed mapping ablation system, but they do emphasize the ablation strategy is also very important. It's not just a technology part. And then, so that's why currently the recommendation is still primary vein isolation, and this is the first line and the primary endpoint. For other facilitated, how many lines we should make, posterior wall ablation, and with Marshall ablation, etc. These are still not they're recommended, may consider to do, but not as the PVI critical as the primary endpoint. So I think overall, I totally agree with you. It's really a good document to reflect the contemporary and current state of management of patients who require atrial fibrillation therapy.
Well, Dr. Cha and Dr. Bhakta, thank you for joining us. And to all our viewers, stay tuned for more HRS content coverage. Thank you.